Thanks very much, Professor Barinholtz. And it's a great honor to be here, and I want to thank BATE for putting together this wonderful program. And I'm going to, talk about microscale cells, but the two direct relevance aspects of these to nanomedicine is that those cells are manufactured using nanotechnology. We use, for instance, RNA to electroporate into T cells. And there are people making engineered T cells now that will carry so-called backpacks, nanoparticles that they can deliver into the tumor microenvironment, taking advantage of the active trafficking of the cells. Disclosing my relationship with Novartis, and I'm going to discuss off-label use of CART19 and CART-BCMA. So what I'd like to do is go over some aspects with the design of CAR cells and their use for cancer therapy, and then finish with, at the end, some brief considerations of the joining of two orthogonal technologies, the growth of T cells and CRISPR editing. And because I noted there's going to be a symposium later in this meeting on genetic editing. So we now, at this point, after many decades, in fact, over 100 years of disappointing results in cancer immunotherapy, Paul Ehrlich really first proposed cancer immunotherapy with the so-called concept of targeting with magical bullets. So that was in the 1860s. And it's only recently now where we have the first generations of cancer immunotherapies using T cells, approved in 2010. Checkpoint therapies, called in this review, became major players in 2014, now approved in the US now for lung cancer, for instance, in diseases not thought to be immune responsiveness. Amgen this year having an engineered oncolytic vector. So this is a herpes simplex virus that's been retargeting for cancer. And there's a pipeline of hundreds and hundreds of different kinds of biologic and cell therapies now for cancer. The therapy that I'll talk about that Novartis is developing for leukemia, the CAR T cell, is anticipated to be licensed in the US by the FDA next year. And that'll be the first genetically modified cell therapy. So this all began really with the results that CAR T cells worked in leukemia. It was called the #1 breakthrough in science in 2013. And #2 that year was CRISPR technology. And I'll show you how those two technologies really have such a potent way to synergize with each other. And this is how a CAR T cell works. So these are, a human T cell is about 7 microns in diameter. They each have about 10,000 receptors specific for one protein in your body. In this case, you could imagine, say, it's a T cell that's responding to influenza. And so that's the native T cell receptor. When we use a genetic modification or electroporation of RNA, we can then introduce the CAR molecule, which integrates into the T cell. And then it's expressed constitutively on the surface of the T cell. So now the T cell's bispecific. It retains its day job, if you will, of the flu-specific T cell receptor, but has an antibody-based recognition domain. And antibodies normally are made by B cells, which therefore comes the name chimeric antigen receptor. It's a chimera in the Greek terms of a B and a T cell. And then if it then encounters a tumor cell that has the target, in this case CD19, it will kill it. And T cells kill with many different ways. They evolved to kill viruses, intracellular infections, and they're non-cross resistant, so that a tumor cell that's resistant to chemotherapy will still die when it encounters a CAR T cell. So what I'm really talking about now is making a synthetic immune system. And I think that's the real focus of this meeting. How do we get synthetic biology to happen? So really making the immune system work better than it does in nature. And so we have both kinds of immunotherapy for cancer and infectious disease. We have vaccines, which employ the natural immune system. Now we're finding that they can be very potent if they target the mutations that are in each individual tumor. I think there's going to be a glass ceiling, though, for this approach because many tumors don't have enough mutations to target with the immune system. And in addition, the human immune system, unfortunately, flags as we get older, so that there will be an aspect of regenerative medicine to make the immune system work better as populations age. Synthetic immune systems, we can install the receptors we wish and tune the affinities. We can genetically modify the T cells so that they're more resistant to immunosuppressive factors. And so we will actually use both of these approaches depending on the situation. So the field I specifically work on is called adoptive cell therapy. It's a form of immune therapy that's called passive therapy. It's putting the cells into a patient. It's not requiring a vaccine response. And there are 3 forms of that now in advanced development. A phase 3 trial in Europe testing so-called TIL cells, tumor-infiltrating lymphocytes, in metastatic melanoma. So that requires a surgically accessible lesion to be biopsied, removed, grow the T cells out, and then give them back to the patient in a simple infusion. The other approaches start with peripheral blood to grow the cells, and then they're genetically modified to introduce either a T cell receptor. And in the US, GlaxoSmithKline with Adoptive has trials underway for sarcomas that will be registered. And then the other approach that I'll focus on are the CAR T cell approach that I just explained. So all 3 now are in advanced development. None are yet commercially approved, but it's on the horizon. And when you look at the consideration of how this will work, there are a number of details that matter, like all science. One is what kind of lymphocyte to use. There are killer cells or helper cells. Immunologists have a list of about 20 different kinds of lymphocytes, and they each have different abilities and trafficking and so on that may be better for one situation over another. Another issue is how to grow the cells, and their miniaturization will be important, and robotic adaptation. Right now we use cell culture approaches that are not optimized. And then the last is the synthetic biology aspect of how the cells are actually genetically modified. So CAR T cells is a concept of making a synthetic molecule that doesn't exist. As I mentioned, it's an antibody fused in frame with signaling molecules that are derived from either the T cell receptor zeta chain or other co-stimulatory molecules such as CD28 and 41BB. Zeli Geshar at the Weizmann Institute made the initial fundamental retargeting of a T cell so that it didn't have the T cell receptor. It had an antibody-based recognition domain. And he first showed that in tissue cultures that you could retarget T cells, and then in mice that you could then make it work to kill tumor antigens of choice. And what the field now is testing are so-called second-generation CARs that have co-stimulatory domains hardwired into them to make T cells proliferate longer after they encounter their antigen. We've recently studied the effect of that co-stimulatory domain on CAR T cells, and we took a T cell that's specific for CD19, which is what our leukemia targets, and then put one signaling domain called 4BB, which activates TRAF2 signaling, or CD28, and we found out it had major changes on the T cell metabolism. So the T cell has the same surrogate antigen now. It will react and kill CD19 specific cells, but it changes its mitochondrial biogenesis, oxidative metabolism, and potential to be a memory cell. And if it has glycolysis, basically cytosolic metabolism, then the T cell proliferates very rapidly and has less chance of persisting long term. So you can specify the fate of cells and change the specificity depending on what the signaling domain is. So that's a very active area of research at this point. So we began giving CAR T cells to patients with HIV infection back in 1997. And that was with a company that's now defunct, but it was called Cell Genesis. And we used a retrovirus to introduce the CAR, and we treated 44 patients. All of those patients are healthy. This is pharmacovigilance data now. We've also now treated with Novartis, as of last month, 219 patients with the CD19 CAR. And what this data shows is there's been no issues of genotoxicity. There have been aspects of gene transfer, for instance, in stem cells, where it's caused later transformation and the development of cancer, and that's always been a safety concern. In human T cells now, we have over 1,400 years of patient safety observation, and we haven't had a single incidence of this. And that's because in the US there is we have to follow patients for 15 years after being treated on a gene transfer study. So this data actually shows that giving gene-modified T cells is safer than chemotherapy. If you look at women who have had chemotherapy for breast and ovarian cancer, there's an incidence in the survivors of 5 to 10% of getting secondary leukemias. So gene transfer is safe in T cells as a baseline technology. So our second generation CAR, called CAR-19, and this is now the unpronounceable name that Novartis has given it, we began treating leukemia patients in 2010. So we now have 6 years of follow-up in those initial patients. There have been 4 papers in the New England Journal of Medicine describing results in acute leukemia, chronic leukemia, and myeloma. And a number of diseases are being treated with these CAR T cells. But the basic design of the studies is the patient donates cells. We manufacture those in a laboratory in a process that takes 5 to 10 days to introduce the CAR molecule. And then the cells are harvested. They're frozen in infusion-ready DMSO. And then the patient, when they're ready for infusion, the cells are taken to the patient's room and they're thawed in a 37-degree water bath and infused. It takes about 5 minutes. So our first patients then treated in 2010 had chronic lymphocytic leukemia, or CLL, which is a disease. It's the most common chronic leukemia in Europe and in the US, and is not curable unless one has a bone marrow transplant. And so we activate the cells with antibody-based beads. They're paramagnetic. We remove those beads, add the lentiviral vector, transduce the cells, and then harvest the cells and cryopreserve them for infusion into the patient. We now have this 6-year follow-up on the first patients treated, and we can measure these cells in the blood because they're genetically modified. So the sequence of the CAR, the nucleic acid sequence, doesn't exist in the normal human genome. So this is a quantitative assay. In this scale, it's a semi-log plot of the copies of the CAR per microgram of genomic DNA in the blood. And what you can see is these are 4 patients who had complete responses. There is a massive expansion into the blood about 10 days after the cells are infused. And at that point, the patient has tumor lysis, and then the cells contract down by 2 orders of magnitude, and they have now persisted. This shows out to 12 months, but we have data out to 5 years. The CARs have persisted in the patients, and it predicts their response. So these are ordered complete responding patients, PR, partial response, and non-responding patients. So the patients who have not had a response, the CAR T cells engraft, so we can measure them in the blood, but they don't undergo the proliferation. And so what correlates as a biomarker of response is proliferation and persistence of the CAR cells. And we don't know in this case if it's an intrinsic failure of the T cells, such as senescence, or if the tumor has checkpoint molecules that are shutting off the CAR cells, and that's something we're studying, so if we can convert these patients from non-responding to responding patients. They continue to have target. In other words, their tumor still has a CD19 target in CLL. It's different in ALL, as I'll mention. So we just presented this data at the clinical oncology meetings, ASCO, a few weeks ago. This is the first 60 patients treated who had acute lymphocytic leukemia, which we began treating those patients in 2012. And this waterfall plot shows from patients 1 to 60 their response. Green is good, and that it means they had a complete remission. And they also have B-cell aplasia. B-cell aplasia, the loss of normal B cells, correlates with responses of both CLL and ALL. The CAR T cells can't discriminate between a normal B cell that has CD19 or a malignant cell. So specificity is very important. So this is a 93% CR rate, which is quite unusual in a phase 1 trial. What we have found, though, is that some patients who lose their CARs, they have a higher risk of relapsing. So, and that's what this study shows. So we think that there's an ongoing immunosurveillance by the CAR T cells, and that's what prevents relapse. The first patient we treated here now has over 4 years of follow-up, and that was Emily Whitehead, who's shown here. When we treated her in 2012, she was had refractory leukemia that didn't respond to chemotherapy, and she had a very severe cytokine release syndrome, and it was driven by, these are cytokines in her blood, so starting here at baseline, day 6 to 7 to 8, she had over 1,000-fold increase in interferon gamma and IL-6. She also had a fever to 41 degrees for 3 days, and that was non-responsive to everything we could give. It turned out that fever was due to tumor lysis. She had several kilograms of tumor that went away. We didn't know what was happening at the time. What we did find out is that this is driven by IL-6, that's this one here, the high fever. And we treated her with tocilizumab, which is a drug that blocks IL-6 receptor signaling. That's a drug made by Roche here in Basel. And so she then, had, as soon as we treated and blocked the IL-6 signaling, the fever went away, she woke up, and tumor is gone. So that trial is now under in multi-center trial globally, as I'll show, for treating acute leukemia. When we began in 2010, there were 3 trials at academic centers in the U.S. testing second-generation CAR T cells. Now, if you check in clinicaltrials.gov and do the search term chimeric antigen receptor, there's 110 trials now underway. So it's a very rapidly evolving technology. But geographically, they're not, there's a geographic disparity. So most of the trials are in North America or China. There's very few here in Europe. And it's not because the basic science hasn't been done. Many of the basic observations were done by science here in Europe. There are regulatory barriers to opening trials here that make it slower and more expensive. So this is the multi-center trial that Novartis is currently conducting for acute lymphocytic leukemia called Eliana. So these are the trials where it's open in the US, the centers, and these are the centers in Europe. At this point, the manufacturing remains patient-specific. So the cells are obtained from the patient's arm, they're shipped. Novartis has a manufacturing plant in Morris Plains, New Jersey. So they're shipped transoceanically, manufactured and then frozen and then shipped back to the patient's site. In the first quarter of next year, Novartis will open a manufacturing plant in Leipzig, Germany, and then European manufacturing will take place there, and eventually the plan is to build these out to local regional areas. So we have seen resistance in ALL. I mentioned that we need long-term engraftment of the CARs. That's what correlates with remission. And the patients who have early relapses have lost their B-cell aplasia and lost their CARs. In some cases, it's because their immune system rejected their own CARs. The other patients that have relapsed have had loss of target, and this should not be a surprise. So they have relapsed with CD19 negative leukemia, and it's a very interesting mechanism of how this happens. So CD19 is an immunoglobulin gene superfamily member. It has 14 exons. And exon 2 is where our CAR binds to. So the antibody moiety binds to exon 2 of CD19. And you can find a splice variant for CD19 where there's no, in RNA, where exon 2 is skipped. And so it turns out there are skipping factors that allow CD19 to be expressed without the CAR binding domain, and then the CAR can no longer kill the cell. So the patients then have CD19 negative leukemia. At least it looks like it's CD19 because all the antibodies to CD19 bind to that second exon. So the treatment for this that we're looking at right now is to treat with a combination of CAR against other molecules other than CD19 to prevent that target loss. That's with CD19. Now, if you look at myeloma is a disease that right now is incurable in most patients, but is usually CD19 negative. There are 5 trials now testing CARs for myeloma, and I'll talk about these CARs for BCMA, which are early trials that are ongoing. So BCMA stands for B-cell maturation antigen. It's a member of the TNF receptor family, and it's involved so BCMA has a ligand called APRIL and BAFF, and these are molecules that maintain viability of myeloma cells and normal plasma cells. And BCMA is specifically expressed on late-stage B cells and plasma cells, and is a good target for myeloma. The trial that we have underway at the University of Pennsylvania with Novartis is shown here at clinicaltrials.gov, but we have a human anti-BCMA antibody, and then the same signaling domains that we use in CART19. It has a 4-1BB and a T-cell receptor zeta chain. The trial has 3 cohorts of patients. The first cohort given in single infusion of 100 million CAR cells and no previous chemotherapy. And then we're planned cohorts where the patients will get lymphodepletion, chemotherapy, and then the CAR infusions. At this point, we've just completed cohort 1. So the trial design, again, is shown here. The patients get biopsied. They get the T cells removed and T cells manufactured, and bone marrow is aspirated at 1 month and 3 months to look at responses and assess for CAR cells. So this is patient 1 who had very late-stage myeloma, 11 prior lines of chemotherapy, and very bad genetics for those of you who are oncologists. This is an aggressive lymphoma that has P53 loss, NRAS, and chemotherapy refractory. So myeloma cells are CD45 dim, CD38 positive, so this is a bone marrow full of myeloma. And at baseline, it had a lot of BCMA expressed. This is 7 days after treatment, looking for CARs in the blood, and there are many CARs. So they proliferate with the same kind of kinetics we see with CD19 CARs, and this is measured by the PCR assay, CARs here in blood, and bone marrow shown in red. So very high levels of CAR happen in this first patient. And this is what happened after at a month. So the patient had now has, where before the bone marrow was full of CD38 positive, CD45 negative myeloma cells, there's no BCMA expressed, and the paraprotein that the myeloma cells secrete has disappeared. So the patient's had a complete remission. So that trial's underway. We see activity with CD19 CARs as well as BCMA CARs. So there are a number of diseases being treated with these CARs. Jens Hoskarl from Novartis is going to talk about the diffuse large B-cell lymphoma results this afternoon in a subsession. The primary toxicity we've seen have been expected as far as B-cell aplasia. There are a subset of patients who have reversible neurologic syndrome that is, at this point, remains unexplained. It appears to be a targeted effect through CD19 because another CD19-directed therapy, blinatumomab, which is a bispecific antibody, also causes that. So those trials will continue. There's a number of other targets being developed for instance, solid tumors and other kinds of leukemia. What I just want to finish with are some considerations on editing DNA and using that as a way to change T cells and synthetically enhance them. So there are a number of tools now to edit genomic DNA, and you'll hear more about this later in the meeting, but we first began working with zinc finger nucleases back in 2003, and more recently now with the CRISPR-Cas9 system to modify T cells. There are many things you can think of that you could do to enhance T cell functions. We first did this to introduce a disease-resistant gene in other words, to knock out the HIV co-receptor in patient CD4 cells and then render the cells, so CCR5 is the HIV co-receptor, make the cells resistant to HIV infection. Because it turns out through mutations that we know that spontaneously occur, that CCR5 is not necessary for the function of the immune system. Another approach is to enhance T cell function by removing the checkpoints in T cells, such as PD-1, CTLA-4, et cetera, and then creating checkpoint-resistant T cells, and that's something we're working on. Another aspect is to make so-called universal CAR T cells. So instead of having patient-specific cells, would it be possible to make cells from either healthy donors or cord blood cells or artificial cells, and remove their endogenous T cell receptors so that they won't cause graft versus host disease. So this would be a very major change to the field. It would be disruptive if we could learn to make universal CAR cells. Right now, the patient-specific cells that we have outlined, I've shown you, that they're autologous. They're manufactured one patient at a time, and they're delivered with a point-of-care business model. If we would have off-the-shelf CAR T cells, it would be more of the standard pharma model, where they would be centrally manufactured with a master cell bank. The point at this point is that the CAR T cells that we make that are patient-specific, they work, they have reproducible activity, but they're complex to manufacture. So we're early in the industry, and we don't know if these will work off-the-shelf cells, and it would be important if they can. And I think in the end, we may end up using both kinds of cells. So we began our initial genetic editing in a trial in 2009. We did this working with Sangamo Biosciences in San Francisco. And it was an open label single-dose study. We used an adenovirus. We're now using RNA encoding a zinc finger nuclease, which is transiently expressed in the T cell as a molecular scissors. It's a restriction endonuclease that removes the CCR5 gene. It's, if you will, a so-called hit-and-run kind of gene therapy because there's no vector or nothing stays in the cell afterwards. It just deletes the gene. The zinc finger nucleases then are metabolized and are only transiently expressed. So we reported this 2 years ago. We had patients, one cohort of patients had their drug treatment stopped for a month after we infused the cells to test if in fact the cells were HIV resistant, and we infused a single dose of 1 billion of these CCR5 deficient cells. The first patient was infused in July of 2009, and this is Bruce Levine, who manufactured the cell. Pablo Tabas is a principal investigator of the study. And what we showed in the paper in 2014 is that the cells engrafted in these patients and had no side effects. And we now have data as more recently that this patient here, more than 5% of his CD4 cells are HIV resistant. So they're CCR5 deficient. So it's an acquired deficiency now where they're not infectable with HIV. So it's a permanent disruption, and so that's heritable within the patient's cells, and he's healthy. So on small numbers of patients, this looks very promising that we could engineer an HIV-resistant immune system and then patients not have to take drugs every day. It's a long-term goal, but I think the technologies are here at this point. We can also use the same kind of approach for cancer. And this is some papers showing issues with the T cell receptor that when we introduce in new T cell receptors, you can have mixed dimers form. Studies by Ton Schumacher have shown that you can make the T cell receptor as a heterodimer, and if you introduce in a transgenic T cell receptor, it may recombine. So removing the endogenous T cell receptor can induce, can increase the function of an introduced T cell receptor. And removing the PD-1 gene can make cells resistant to exhaustion. So we're now approaching this using the CRISPR-Cas9 system, which is extraordinarily flexible. We can target 3 genes at one time, so multiplex editing, expressing the Cas9 nuclease with guide RNAs. In our case, we're using guide RNAs for the T cell receptor alpha, beta chain, and PD-1. And these are some references. Almost every month, a new approach comes out increasing either the specificity or the efficacy of CRISPR technology. So we're looking then here to generate cells that don't get turned off by the checkpoint molecules such as PD-L1, which is normally in the tumor microenvironment. This is a study from Tom Gajewski several years ago where he made, using mice, he bred PD-1 deficient T cells. These mice have a tumor. It didn't respond to T cell receptor adoptively transferred T cells, but if they had a gene knocked out for PD-1, they did control the tumor. And so that's part of the rationale for making checkpoint resistant T cells. And at this point then, there are a number of genes that can be targeted, and I think we'll see an explosion of this. There have been a patient reported in the lay press, still not published scientifically, the so-called London baby case that you may have heard about at the beginning of this year, where a child had refractory leukemia. They were unable to manufacture autologous CAR T cells for the patient. They manufactured third-party cells from a healthy donor and used talons, another nuclease, to knock out the T cell receptor and then introduce the CD19 CAR, and the patient then had a remission and then was transplanted. So that's the first instance of using a universal CAR T cell in patients. And so I think we'll see a very rapid proliferation of cells doing these different approaches with a number of different editing technologies. Just last week, we presented in the U.S. any trial using genetic editing or new human gene transfer technologies needs to go through, it's called the RAC committee, and we presented our case last week, and it was approved unanimously, so that our trial is going to proceed using CRISPR engineering with T cell receptors. It's called the NICE trial, which is New York ESO1 redirected T cells using CRISPR edited T cells. So we anticipate that trial will begin at the end of this year to test if editing with CRISPR is safe. So we're entering this era now where we've had a number of armamentarium for T cell for cancer therapy for very long periods of time, chemotherapy and radiation and surgery. And then more recently, targeted small molecule drugs, antibodies, et cetera, vaccines, cytokines, and we'll have CAR-based T cell therapies. And the major issue is going to be how do we combine these therapies. We don't, at this point, have good preclinical models that say how and they should be combined. In many model systems, there's reason to believe they'll be synergistic. And I think we'll spend quite some time working those conditions out. So I've reviewed some aspects of CAR T cells. After many years now, adoptive cell therapy is heading towards FDA approval in leukemia, in diseases as diverse as melanoma to leukemia and lymphoma and sarcoma. The major issue really in the field is manufacturing these cells. That's an engineering issue. At this point, we have antiquated technology for growing cells that have really never been developed at a pharmaceutically robust level. And we're going to see increasing use of an orthogonal technology, which is genome editing to synthetically enhance T cell function further. And a number of people are involved in the studies at my university and as well here in Basel with Novartis. And I'd like to thank you for your attention. Thank you.
Okay, we open the session to questions. Please.
Thank you very much for a very interesting presentation. It looks that adoptive transfer is leading now as compared to vaccination. Do you think that in the near future we would be able to overcome this delivery thing with peptides, gene proteins, etc., to the T cells specifically?
You mean use a vaccine rather than, yeah. So I had a slide comparing synthetic immunology to natural immunology. Vaccines for a long time have been used in cancer and they haven't really worked. We now know part of the reason why that is, and that's because they were targeting molecules that we have very high levels of tolerance, meaning the immune system's been trained not to respond to the vaccine, target antigens. But now with genetic sequencing of cancer genomes, we can identify mutations in tumors, and those not infrequently create new antigens or neoantigens in the patients, and then there can be a much better response when you vaccinate. That's just beginning now technology. And so in patients who have, for instance, melanoma patients have thousands of mutations, and most lung cancers have thousands of mutations. And so if the immune system can be trained with vaccines to respond to those, I think there'll be very good efficacy, and that will probably combine with checkpoint therapies. But I also mentioned, ALL, leukemia, it takes only 3 mutations to get leukemia. They're called gatekeeper mutations. And so there's a very small mutational landscape. So targeting that with vaccines is probably unlikely. And I think synthetically redirected cells. So I think in the end, we're also going to see vaccines used to boost adoptively transferred cells. So I think that we're going to have both, vaccines are going to get more potent because of the cancer sequencing and combined with checkpoint therapy, and then the adoptive therapies are going to get, be focusing with synthetic engineering.
Please.
You mentioned in some of the patients that develop resistance to the CAR T CD19, for example, the CAR T cells titer was low or disappeared after a while. Is there a benefit to redosing these patients, and has that been explored?
So we're just beginning to do exactly that. So we think you need an area under the curve of probably 6 months of having CAR therapy to introduce, at least in ALL. Acute lymphocytic leukemia. So what we're doing now is prospectively monitoring patients, and if they lose their CARs, meaning their B cells come back, then we're reinfusing, and that appears to work. But I also mentioned we don't yet know the mechanism why some patients lose engraftment and others don't, and that's it may be either the tumor has shut off or killed the CAR cells, or it may be that some patients, either after a lot of very vigorous chemotherapy or their T cells just don't work as well. So that's an area of research.
And have you looked at the PD-1 aspect of this? Is that the cause of resistance?
So we have a trial right now that just opened to test that. So we believe it is a major cause of resistance in diffuse large B-cell lymphoma. And I think Jens Haskarl is going to address that this afternoon. But so it turns out certain forms of lymphoma much overexpress PD-L1. We haven't seen that in ALL, so acute pre-B-cell leukemia, there seems to be no checkpoint resistance. So it's depending on the tumor subset type, there's very different kinds of immune escape.
Please.
I was interested in your reflection about universalizing your system in context of what Patrick said this morning about the future is personalized medicine. It sounds like you've got, in what you described, I'm not at all an expert here, very individual. And in a sense, is that the saying really, personalized medicine does eventually have an endpoint beyond which it's either not practical for general use or only very specific? But presumably the universe, so you said that the future may be somewhere between the two. Can you expand on that?
Yeah, so, I mean, that's a central issue. I think there'll probably be two kinds of use. One, sort of an off-the-shelf thing where a physician could have frozen cells that were made off from a master cell bank, and they may only work for 3 weeks in a patient, but if they may work then for a tumor, induction of a remission. I think the long-term persistence of autologous cells is going to be a very useful mechanism. That's probably what leads to long-term remissions. I mean, the only really previously curative therapy for most leukemia was a bone marrow transplant, and it's thought that reason that is the donor T cells persist in the patient. And so I think we'll have sort of and in other oncology, we have so-called induction therapies and then consolidation therapies. So I think both forms will be used as in an armamentarium. Logistically, it's much simpler to have a master cell bank rather than these N of 1, which is, as you're saying, it's like the ultimate of personalized therapy that way. So I think we'll have both. And it's major efforts now by the pharmaceutical industry to learn how to scale these. This is not an issue of scaling up, which is what it was in the biotechnology industry. There it was, how could you learn to make kilograms of an antibody? Where in this case, it's scaling it out. It's learning how to do it many times. But we don't need that many cells per patient. But they have to, at this point, be patient-specific.
Can you comment on on the role of CAR T cells in the treatment of solid tumors? And what do we know about the homing of these engineered T cells to solid tumors?
The solid tumor microenvironment is more complex than in hematologic malignancies. In many solid tumors, they've evolved for 10 years, maybe before the patient actually presents. And so there are many subclones of the tumor. Now, where therapy was first tested, there's so-called TIL therapy for melanoma, a solid tumor. And the T cells home back in. You can take them from a metastatic lesion. They home back to the tumor, and it has demonstrated efficacy in about half the cases. The other solid tumor right now that has been tested and shown really to work well with genetically modified cells is synovial cell sarcoma, which is a solid tumor that often metastasizes to the lung, and that's 3 different groups have shown that that's very responsive to T cell receptor modified cells that target the antigen New York ESO1, which is what we're going to target with our CRISPR trial. Now, if you take, but right now, no one has shown, for instance, that pancreatic cancer will have massive responses to cell therapy. But if you take the cells out, say a pancreatic cancer cell or lung cancer cells, and in Petri dish and expose them to CAR T cells. The CAR T cells kill the tumor cells. So adenocarcinoma cells die when they encounter these engineered T cells. The issue is going to be, as you're saying, trafficking in, and what is that efficiency? So there are a number of strategies to increase the efficiency of trafficking, and the field's just beginning to look at those. It's literally they're just starting those trials in phase 1. At several centers.
Please.
It appears that this field could benefit from the rapidity of feedback of liquid biopsies. Is there any work of that type going on?
Yeah, so that's, we've found that to be very much true. So liquid biopsies, for instance, in solid tumor trials, where we can't often get we're lucky in leukemia, if you will, because standard of care is every patient gets a biopsy a month after they're treated. And so for instance, did the CAR T cells get there and did the tumor respond? But if you treat glioblastoma, so one technical limitation right now is we can't image these CAR T cells. And it would be very useful to have an imaging technology to detect them for trafficking and expansion and so on, to know, did they get into the tumor? And then liquid biopsies to know, for instance, does the tumor still have the target? And so on. So that is going to be it'll be a complementary technology.
Thank you for your presentation. I wonder if you could comment about the level of CAR T transduction. Is that going to be linked towards efficacy for different kinds of tumors?
So that's what we thought initially. And then the second patient we treated, actually, who was on that video that you showed, his name's Doug Olson. He's a PhD hematologist. He had only 5 or 3% of his T cells were transduced. And so what it turns out is they're positively selected in the patient. And so you need very low levels with the CAR targeting. They proliferate when they see targets. So there seems to be a minimum threshold amount, just as in a bone marrow transplant, that has to be transferred into the patient, and then they expand out. So it's not an issue here. Now, I think in certain gene replacement approaches, then efficiency of transduction is going to be limiting. But at least with the CAR technology, a very low efficiency, quite to our surprise, works.
Good enough.
It's good enough. Yeah, it doesn't have to be perfect. What matters probably is tumor contamination, making sure, for instance, if you start with a leukemia patient, that you're not reinfusing leukemia. And I didn't mention that, but we test that.
And we have the last one, please.
As an oncologist from this country, we are quite unlucky to have this technology not available. Even, I believe, we have a high experience in immunotherapy and have the infrastructure like GMP facilities. Any advice that you could give us how we could move forward in this regard?
So I know, for instance, my colleague, George Kukos, has moved to Lausanne. So at that cancer center, they're building now, in that canton of wherever Lausanne's canton, is making a GMP facility, and we'll be working with him to have local trials here in Switzerland. I mean, Novartis will have, trials there, and we're working with a glioblastoma group, hopefully to have trials open here in Switzerland. So it's going to be developing now both, I think, at an academic level and then standard pharmaceutical trials that will be underway.
Okay, I think we are all eager for lunch, so I think we're closing the session, and I want to thank Carl for...
Thank you very much.